My name is Eldrin Lewis, and I'm an associate professor of medicine at Harvard Medical School and a heart failure and transplant cardiologist at Brigham and Women's Hospital. Today I will talk with you about heart failure with preserved ejection fraction. These are my disclosures. The objectives are to recognize the heart failure phenotypes in patients with preserved ejection fraction and risk factors that may lead to its development. The second objective is to understand application of therapies to improve outcomes and review clinical trials to date. And then finally, to review strategies to improve care of end-stage heart failure with a focus on quality of life. Heart failure is a significant problem across the world. In this study, which is dated with the World Health Organization, there are 22 million people in the world who live with heart failure. We now know that in the United States there are approximately 6.5 million people living with heart failure with an annual incidence rate of approximately 600,000. Surprisingly, at the age of 40, the lifetime risk of heart failure in the United States is about 21% for men and 20% for women. When we think about heart failure, we often have to think about the risk factors. And certainly one starts with diabetes and hypertension, and traditionally this leads to atherosclerosis and left ventricular hypertrophy. It may result in myocardial infarction, and because of things including hypertension, there's pathologic remodeling, traditionally leading to ventricular dilatation, heart failure, end-stage heart disease, and ultimately death. This is a model that was really developed primarily for heart failure with reduced ejection fraction. However, we know that pathologic remodeling tends to be in the form of significant hypertrophy, typically in the setting of hypertension. We want to interrupt the progression of disease because we know that these patients have neurohormonal activation, endothelial dysfunction, vasoconstriction, as well as apoptosis, fibrosis, and renal sodium restriction. And this actually accelerates the remodeling process and leads to the clinical diagnosis of heart failure. Now, when we think of heart failure with preserved ejection fraction, or HFpEF, we know that there are some compensatory mechanisms that happen that allow the patient to consider or to continue to function in the setting of an abnormal injury. So the adaptive response to a decreased cardiac output or decreased blood pressure includes sympathetic activation, which can result in norepinephrine levels and epinephrine levels, as well as dopamine levels increasing. But also renal hyperperfusion can cause sodium and fluid retention, as well as increases in angiotensin II, aldosterone, and renin. We know that increased cytokines and increased stress can stimulate the natriuretic peptides, which also can be a compensatory mechanism. But over time, the increased afterload, increased preload, as well as the tachycardia and increased contractility can lead to a maladaptive remodeling process. For the sake of heart failure with preserved ejection fraction, this is mainly hypertrophy, but you certainly can have dyssynchrony and even arrhythmias, leading to apoptosis, myocyte loss and weakness, and ultimately dysfunction of the heart. Oftentimes, one thinks of heart failure with reduced ejection fraction, and this is primarily because the majority of the studies that have been done in this population. However, in looking at the cardiovascular health study, about 31% of men would have a significant reduction in their LV function, and in fact only 10% of women. So the entity that I'm discussing with heart failure with preserved ejection fraction unfortunately affects 67% of women with heart failure and 42% of men. And it's a shame that we don't know much about therapies that have been proven to be beneficial, because overall the mortality rate is similar and the quality of life is quite similar as well, which I will share with you in a few minutes. There are some difficulties and controversies to managing heart failure with preserved ejection fraction. Some people will say it's just a collection of risk factors. You just have patients with hypertension, diabetes, and kidney disease. There's also the concern about the heterogeneity of the patients, and one would say it's really challenging to study this population because they're so difficult and they're so different. There's lower specificity in the setting of dyspnea when you have HFpEF compared to a reduced ejection fraction. Once you see that the ejection fraction is low, it certainly increases the specificity that it's due to heart failure. However, one can have dyspnea from many causes, as we will discuss. And I'll start with some of the diastolic measures. So one way to measure diastolic relaxation velocity is the tissue Doppler imaging, and it's also the E prime. This is the line of abnormality, and numbers that are lower than this, around 8, are considered to be evidence of diastolic relaxation abnormalities. And as you can see in trials with preserved ejection fraction, a lot of these patients have abnormal diastolic relaxation velocity. However, if we look at a population of patients with risk factors, but no diagnosis of heart failure in the ERIC study, their actual TDI, early diastolic relaxation, or E prime level is about the same. So once again, the specificity is somewhat limited. We can also look at the E over E prime ratio, and we know that a level that exceeds 10 to 11, or really 10.5, is considered abnormal. As you can see, for all of the heart failure trials, these patients had abnormal E over E prime ratio, as you would expect. However, once again, in the patients without heart failure, in the ERIC population, you see a large number of those patients have these same abnormalities. So we can't just look at diastolic dysfunction. Well, what about mortality? If this is just a constellation or combination of risk factors, then I would expect patients with hypertension and diabetes or vascular disease would have a similar all-cause mortality to that of patients with what we call HFpEF. But in fact, if you look at hypertension and diabetes studies, as well as studies looking at stable myocardial infarction patients who don't have LV dysfunction or heart failure, and if you look at patients with vascular disease, on average, their annualized mortality rate in the placebo arm ranged from 1.1 to 2.9%, even with patients with kidney disease. Even if you look at the extreme elderly patients, so those patients over the age of 80 in the HIVIT trial, their risk of all-cause mortality was 6%, as you would expect, given their age. However, if you look at patients with heart failure, you see the annualized mortality rate in 1 year of about 5.3 to 7.7%. So joining the heart failure club is associated with about a 4 to 5-fold increased risk of mortality. What about heart failure hospitalizations? Well, the same thing. If we look at these same studies, in general, your risk for heart failure hospitalizations, if you just happen to have a collection of risk factors, such as hypertension, vascular disease, diabetes, or chronic kidney disease, ranges from 0.5% to 1.5% per year. However, if you were enrolled in one of the heart failure trials, it ranged from 5.6 to 9.7%. And I think if you wanted to look at a comparison or a comparator, I would look at the TopCat patients enrolled in Russia and Georgia. These patients, we feel, did not have heart failure, but probably had risk factors, hypertension and coronary disease. And you can see that their annualized risk for heart failure hospitalization of 1% is very comparable to those patients who had these exact risk factors. So once again, even though it's difficult to define, you can't say that this is just a collection of risk factors. If we look at quality of life, whether a patient has a reduced ejection fraction or preserved ejection fraction in red and blue respectively, you see that the distribution is exactly the same. And in fact, if we start trying to look at the mean score, and this was in the CHARM study, their score was about 41. With the Minnesota Living with Heart Failure questionnaire, a lower score is actually consistent with an excellent quality of life. And as you can see, the mean score was equivalent, if not worse, than a lot of the other traditional clinical trials that looked at patients with reduced ejection fraction. And in fact, if we look at the summary score, the emotional score, the emotional domain, or the physical domain, in general, they're numerically about the same. And if anything, the patients with preserved ejection fraction had a worse overall outcome for the physical limitations related to their quality of life. Well, then what are the pathways to HFpEF? Well, we've just talked about some of the pathophysiology, but there are some unique features that you see in HFpEF. Certainly you have the comorbidities, and the common ones include patients with metabolic syndrome, obesity, type 2 diabetes, and hypertension, as well as patients with renal insufficiency. And these patients end up developing systemic inflammation and activation of their inflammatory cascade, including CRP and GDF-15. And this systemic inflammation causes multi-organ inflammatory responses that can lead to pulmonary hypertension in the lungs. It also can lead to some heart changes, which we'll talk about, as well as skeletal muscle changes, including sarcopenia and vasoreactivity that is diminished with the blood flow. But also it leads to sodium retention. And we know that the inflammatory cascade leads to endothelium cardiomyocyte signaling, including reactive oxygen species, which reduces nitric oxide and can lead to a variety of reductions, including a reduction in the cyclic GMP and PKG, which can lead to hypertrophy. And overall, as the heart gets thicker, these patients become more symptomatic and they have increased volume. When we think of the stages of heart failure, these were really originally created for heart failure with reduced ejection fraction, starting with the stage A patients who are at risk with no symptoms, stage B patients who have structural abnormalities but no symptoms, stage C patients who have structural disease but they've been symptomatic at any point, and then stage D patients, which represents about 250,000 patients in the United States. And these patients are either class 4 heart failure for 45 out of 60 days, or they're consistently in a New York Heart Association class 4 functional capacity. Now, as we look at strategies, most of these strategies have been developed, unfortunately, for the heart failure with reduced ejection fraction population. And it doesn't necessarily apply to the HFpEF population. However, if you look at the overall prognosis, we know that the patients at risk, either whether they're with or without structural abnormalities, have a survival that's somewhat similar to those patients who don't have risk factors. But in the patients who've developed symptoms, they're in stage C, you can see that there's a progressive decline in their overall survival, and the stage B patients have a survival that's quite limited, with a median life expectancy in many populations that is much less than 2 years. So what can we do to prevent heart failure in the first place? Well, we would like to start with the primordial options, and that is trying to prevent risk factors before they even develop. So we can do this by educating children, by educating young adults, and trying to encourage patients to lose weight, to make exercise a routine part of their daily life, 45 minutes 3 to 4 times a week minimum, to avoid toxins that can lead to cardiomyopathy, as well as identifying genetic polymorphisms that may identify a population who would be at risk for future genetic changes that can lead to heart failure. There are dietary changes as well, and we know that all of these can try to prevent the constellation of risk factors. Unfortunately, in the United States, we're not that good at the primordial prevention. So then we can go to primary prevention, and these are patients who've already developed hypertension or diabetes, and you want to prevent them from developing the secondary issues, including myocardial infarctions, stroke, heart failure, and chronic kidney disease. So in these patients, in addition to everything that you would recommend for primordial prevention, you would also want to try to make sure that their blood pressure is under adequate control, targeting a systolic blood pressure of less than 120 and a diastolic blood pressure of less than 80. You want to control their sugar and make sure their hemoglobin A1C is as low as possible. Reduce proteinuria and screen for proteinuria for those patients at risk for chronic kidney disease, and also to provide protective treatment during cancer treatments. So as we are trying to cure their cancer, they're not left with risk factors for heart failure. But also we want to educate them on behavioral changes that they can make, as well as address all of the components of primordial prevention. In those patients who actually develop true heart disease, whether it's a myocardial infarction or cardiomyopathy with structural abnormalities, then we have to focus on secondary prevention, where we'll put a lot of effort into the post-MI care, addressing the adequate treatment of the stage B cardiomyopathy to try to prevent them from becoming symptomatic, treat peripheral arterial disease, chronic kidney disease, and proteinuria, as well as addressing all of the components that I've addressed in the primordial and primary prevention strategies. In patients who've already developed HFpEF, there are three main components of treatment. The first is from a cardiac physiology perspective. We want to improve diastolic relaxation, slow the heart rate in many cases to improve filling time, diastolic filling time, to improve the myocardial oxygen supply and demand balance, and this could be addressed by addressing coronary artery disease, as well as to reduce congestion. We also address the peripheral physiology. We know that lowering their blood pressure and lowering their systemic vascular tone can actually improve their overall conduit vessel function and can improve the coupling with the ventricle and the aorta. And then finally, from a structural perspective, you want to look for regression, for strategies to cause regression of cardiac hypertrophy and to reduce fibrosis. So when a patient presents to your office with dyspnea and they have a normal ejection fraction, it becomes more challenging because of the heterogeneity and because of the difficulty with making the diagnosis. So an algorithm would be to do an echocardiogram and to look at diastolic dysfunction. So if the average E prime is less than 9 centimeters per second, then you can look for increased LV filling pressures if you have an average E over E prime rate that's greater than or equal to 13. If they have that, then you would make the diagnosis of HFpEF. If not, then you also look for a variety of other strategies. And one strategy that I would bring attention to is the N-terminal proBNP, because it's an easy biomarker to measure. And if it's elevated, it increases the specificity for the dyspnea being due to heart failure. If you have two of these, or if then you can consider a catheterization to try to evaluate them. If they don't have diastolic dysfunction, then you want to look for other things, including constrictive pericarditis, dynamic mitral regurgitation, chronotropic incompetence, as well as dyspnea, which could be an anginal equivalent, and then finally non-cardiac dyspnea. Other management strategies include to measure natriuretic peptides both as a diagnostic marker, but also as a marker to follow to see if there's improvement with therapy. You want to look at other biomarkers of fibrosis, and there are several that have recently been approved and are being used, including the ST2. Cardiac MRI and PET scan can be quite useful, and then exercise testing as well. Now, work by Sanjeev Shah using machine learning realized that there are some distinct clinical presentation phenotypes that are on the x-axis, and if you look on the y-axis, you can look at the HFpEF predisposition phenotypes. So the four predisposition phenotypes include being overweight, obesity, the metabolic syndrome, and type 2 diabetes, but you also have arterial hypertension, renal dysfunction, and coronary artery disease. If you look at the five phenotypes, we know that there are patients who have primarily lung congestion, some patients have chronotropic incompetence, some have pulmonary hypertension, type 2 pulmonary hypertension, skeletal muscle weakness is a fourth one, and then atrial fibrillation is a fifth one. So for patients who are overweight, in general, you want them to reduce their calories. And you want to use diuretics if they have congestion, use rate adaptive atrial pacing if they're chronotropically incompetent. And really for all of these, you would want to consider that, or look critically at their nodal agent. So if someone is on both a calcium channel blocker and a beta blocker, and they have chronotropic incompetence, you could also consider reducing the dose of one and consider substituting another agent for control of their hypertension. If they have pulmonary hypertension, one can look for pulmonary vasodilators, although the trials have not been promising to date, and I will go over that in a few minutes. And for skeletal muscle weakness, you would use exercise training, and then anticoagulate most of these patients because they will have a CHADS-2 vascular score that would really be high enough to warrant anticoagulation. For arterial hypertension, you would use an ACE inhibitor or ARB pretty standardly for all of these categories. And for renal dysfunction, you would use ultrafiltration if necessary. And then finally, for coronary artery disease, have a very low threshold for revascularization. So based upon the 2013 guidelines, class 1 indications would be to control systolic and diastolic blood pressure as well as to use diuretics. And 2A indications, meaning that you should do it, include coronary revascularization for patients with CAD and angina, with a management of atrial fibrillation according to those guidelines, as well as the use of beta blockers, ACE inhibitors, and ARBs for hypertension. If we look at large randomized clinical trials, I can actually just spend a few minutes on those because there hasn't been many. In fact, you have the CHARM Preserved, which looked at candesartan versus placebo in patients with an ejection fraction that exceeded 45%. And there's a trend in the right direction. And when you adjust it for the imbalances, there was a significant risk reduction of 14% in cardiovascular death or heart failure hospitalization. However, in a larger study with irbesartan, another angiotensin receptor blocker, there is no benefit at all with a hazard ratio of 0.95. These are the summary of some of the four trials, the CHARM trial, which I just mentioned, as well as the iPreserve. But also there was a DIG, and they had a preserved ejection fraction arm with about 1,000 patients. The trend was in the right direction with a reduction in heart failure death and hospitalizations. However, it did not meet statistical significance. And in PEP-CHF, looking at perindopril, there was a trend in the right direction again that did not meet statistical significance in 850 patients. So based upon these collection of trials, ARBs got a 2B indication saying that they might be used to consider to decrease hospitalizations in HFpEF, but there was no clear benefit for nutritional supplements. What about TopCat? So this is a trial that we did, enrolled 3,445 patients with preserved ejection fraction heart failure and randomized them to spironolactone versus placebo. In the overall trial, there was a trend once again in the right direction, but did not meet statistical significance. However, heart failure hospitalization, which was a key secondary outcome measure, was met with a 17% statistical significant risk reduction in heart failure hospitalizations in patients who were randomized to spironolactone, and the overall heart failure hospitalization rate was lower too. However, we realized that there was a significant regional variation, such that in the Americas, where patients had an event rate that was commensurate with what you would expect with heart failure, you actually saw a significant risk reduction of 18% in the primary outcome of death or heart failure hospitalization. In the Republic of Georgia and Russia, you could see that the event rates were much lower and there was no difference between spironolactone and placebo. Moreover, we looked at the metabolites in TopCat and we realized that for patients who were assigned to spironolactone or placebo, in the United States, you did see a lower percentage of people who actually adhered to their study drug if they were on the active treatment. But there was no difference between placebo and spironolactone in Russia. If you look at the patients who said they were taking spironolactone, we looked at canrenone, which is a metabolite of spironolactone, and you can see that 30% of patients had no detectable canrenone, suggesting that despite them saying that they're taking spironolactone, they were actually not even taking the study drug. Only 3% of patients in the United States and Canada fit into that category. And if you kind of look at the difference between Russia and Georgia and the United States, the concentration was much higher in the United States and Canada than it was in Russia and Georgia, and the correlations were significant between the dose that was reported and the canrenone level, but you didn't see that in the patients who were in Russia and Georgia. Then finally, just to show that it's not a difference in metabolism in the Russians and the people from the Republic of Georgia, in the patients who had detectable canrenone concentrations in Russia and they had a normal increase in the serum potassium with spironolactone, as you can see. And for the people who didn't, they did not. And this is the same thing that we saw in the United States and Canada. You see the same issue with aldosterone. So patients, the aldosterone increased in the patients who were on, had canrenone detected, but if they didn't, there was a decrease in the mean aldosterone level from baseline to 12 months. So as we look in the serum potassium, one thing you have to be careful with is hyperkalemia, and we saw this. There was a twofold higher risk for hyperkalemia and a lower risk for hypokalemia. And in fact, if you look at the acute kidney injury as well, defined as doubling of the serum creatinine, you have a 50% higher risk for the use of spironolactone. So based upon this study, the 2017 guidelines added that you can actually use, in patients with HFpEF, elevated BNP or heart failure admission, and an acceptable GFR, you can actually use an aldosterone receptor antagonist to decrease hospitalizations in HFpEF. Well, what about exercise, diet, nitrates, and outcomes? Overall, there was no significant difference in outcomes in patients who were randomized to nitrates. And in fact, we have the NEAT study, which looked at isosorbide mononitrate, and you can see that in general, there was no difference in the increase in accelerometer units or the increase in exercise in the patients randomized to isosorbide mononitrate at 120 milligram dose or in the hours of activity per day that they were exercising. So the treatment difference was actually a significant difference in favor of placebo, suggesting that we should not use nitrates routinely in patients with HFpEF. What about the PDE5 inhibitors? Well, this looked at sildenafil versus placebo in 185 patients with preserved ejection fraction. And here you can see the overall patient population. And in general, there was absolutely no difference or no benefit in the primary endpoint or any of the significant secondary endpoints as well, suggesting that routine use of sildenafil or PDE5 inhibitors in patients with HFpEF should not be used. So as a consequence, the new guidelines last year stated that the routine use of nitrates or phosphodiesterase inhibitors to increase activity or quality of life should not be used. It's a class 3 indication. No benefit. Now, because of time, I'm actually just going to highlight a few other things. Sleep apnea is significantly important in patients with heart failure, and HFpEF patients tend to have significant obstructive sleep apnea. The new guidelines suggested that it's a 2A indication that in patients with a suspicion of sleep disordered breathing, a formal sleep assessment is reasonable, and also it's a 2B indication to actually use CPAP to improve sleep quality and daytime sleepiness. And this is key because it's for obstructive sleep apnea. We know in the reduced ejection fraction that positive airway pressure may be associated with harm with adaptive servo ventilation. But there are some residual challenges in the heart failure management, including optimizing medical therapy and bringing the data that we learn in trials to the bedside to come up with uptake of medical therapies, to increase the uptake of medical therapy post-trials, to improve 30-day readmission rates, to come up with better strategies to manage HFpEF, and to assess improvements in prognosis, symptoms, quality of life, as well as addressing advanced heart disease. We know that heart failure hospitalization is significant. Once one person has been hospitalized for the first time, in general, about 40% of those patients will have died by 2 years. But if they had a second admission, about 55% of those patients will die. And you all the way up to the fourth admission, approximately 70% of those patients will die. So not only do we want to reduce hospitalizations for economic reasons, but also to improve overall survival. We know that the timing of the first readmission over the lifespan is diurnal. It changes. It actually is highest in the beginning, right after a hospitalization, and towards the end of life as they're approaching the end stages, with very little variation through the rest of their life. When we look at 30-day readmissions, we know that in the United States, there's a penalty. And so there's been a lot of work focused on why they get readmitted. And we know that about 50% of these patients get readmitted specifically because of heart failure, and about 25% because of non-cardiovascular reasons, of which 5% are because of renal causes. But 25% of these patients get readmitted for another cardiovascular event that's not related to heart failure, including syncope, stroke, hypotension, myocardial infarction, and chest pains, as well as arrhythmias and aborted cardiac arrest. So what can we do to reduce admissions? Well, the first thing is to identify the risk on admission. You want to understand the patient's age. We know that older age, or actually younger age, and severe older age, as well as recurrent hospitalizations, abnormal vital signs, multiple comorbidities, as well as chronic kidney disease, acute injury, and elevated markers, as well as their insurance status or lack of insurance. All are patient-level characteristics that can identify higher-risk patients. But there are also some psychosocial factors, such as cognitive difficulties, which can make it very difficult for them to understand disease management and to implement strategies. The presence of depression and anxiety, as well as adverse coping skills, the lack of a caregiver and family support, as well as impaired learning capabilities and poor communication skills. Language barriers often can impact readmissions as well, because a lot of the material may be published in English when that's not their first language. And then financial constraints can lead to non-adherence to medications because of lack of affordability. And even basic things such as transportation or the cost of parking can do it. During the hospital stay, you want to optimize your medications, establish trust and relationship with the patient as well as the caregiver, and assess the patient and caregiver responsiveness to the treatment that you're providing. You want to engage them in goal setting and establish patient-centered preferences and limitations. If you have a better understanding of what their goals are, you can try to meet them as their provider. You want to assess and reinforce knowledge of disease as well as a self-care plan, and coordinate to reduce barriers to implement the care plan. And in fact, I would say prior to discharge is incredibly important for medication reconciliation and to optimize their medications, address the access to barriers to care, including the affordability of medicines, and schedule early follow-up, hopefully within 48 to 72 hours, but definitely within 7 days. And you want to reinforce the heart failure education as well as the self-care plan. You also want to ensure there's an integrated interdisciplinary collaboration and coordination, provide the health records with key details of the hospital as well as a post-acute experience to the discharge providers, including the primary care doctor, and then transmit the handoff documents to the post-discharge providers in a timely manner. In a multivariable model, there were 6 strategies that were significantly associated with a lower 30-day readmission rate for these patients. That includes partnering with community physicians and physician groups, partnering with local hospitals, having a nurses responsible for medication reconciliation, because oftentimes physicians don't have the time and may gloss over some things, arrange for follow-up visits before discharge, and have a process in place to send all discharge and electronic summaries directly to the PCP. You also want to assign the staff to follow up on test results after the patient is discharged so things don't slip through. We know that on average, despite this data, that the median follow-up visit within 7 days, about 37% of hospitals will actually have a median follow-up visit of within 7 days, and you can see the variation. However, because of the penalties that have been enacted by Medicare, right now we're seeing a trend upward in the number of patients who are actually seen within 7 days. And the key is that they do not need to be seen by a cardiologist. They could be seen by a nurse, primary care physician, or a nurse or a physician extender. And these temporal changes will likely continue over the years. What are some predictors of 30-day readmissions? Well, I kind of alluded to age before, and it's somewhat bimodal in nature. In general, older age, believe it or not, predicts a lower risk for readmission. And some of that may be a competing risk in that these patients may be higher risk of dying. But some of it may be that they're more adherent to their medical therapy. Other predictors include a low hemoglobin, a low hyponatremia, systolic blood pressure that's lower, as well as a higher heart rate, higher BUN, troponin elevation, N-terminal pro-BNP elevation, as well as serum creatinine that's higher. We also found that patients who are self-described Black are at higher risk for readmission as well. So as we conclude, we have to remember that this is not just a HFpEF, or heart failure with preserved ejection fraction entity. This is actually a person who happens to have a disease that's quite difficult to manage. So it's important that we use an integrative model to treat the patient as a whole person. And this includes a personalized treatment plan and multidisciplinary management that includes targeting symptom management, engaging the family and caregiver to provide adequate emotional support, and ensure adequate nutrition and educate them about low-risk strategies to lower their sodium, as well as targeting physical therapy and occupational therapy, especially for those patients who have sarcopenia. And we must remember that patients can have sarcopenia despite being obese. We want to engage the primary care doctor as well as the appropriate specialty care, including endocrinology, nephrology, and other factors or specialties. We want to provide supportive care and counseling, work with the social worker and psychiatry to address depression, anxiety, and some of their social needs, as well as provide spiritual support and coordination to ensure affordability. So as we integrate this model, we know that heart failure, unfortunately, the quality of life gets worse as patients go from primordial prevention to hypertension all of the way to heart failure. And in these patients, we need to follow from an acute illness model to a chronic illness model, where we try to manage them just as we would manage other chronic diseases. And in fact, as these patients approach the end of life, they become less focused on survival and more focused on symptoms. And we need to adjust our strategies to accommodate them. And these patients who are approaching the end stages or stage D heart failure, that's where we have to think about at what point should we consider hospice. And then we can't forget about the family who's left behind once the patient dies, and help them with the bereavement process, and help them through the 5 stages of grief, which are commonplace in these patients' families. So as their disease progresses, we may transition from the usual care team, which consists of the primary care doctor, the cardiologist, the nutritionist, and the physical therapist, as well as focused on prognostication and active treatment. And as they're approaching the end of life, where symptoms and focus on quality of life become more important, the co-management becomes incredibly important. But we have to recognize that there's a variable time course, and this may not just happen rapidly as it would in some patients, but it could be a gradual decline over the course of years. We have to have defined roles, and in fact, the palliative care team can be very instrumental before the patients reach hospice, because they can focus on symptoms while you, the cardiologist, and the primary care doctor can focus on life-extending therapies. They can help with symptom management, communication, establishing the goals of care, as well as helping the caregiver and the family for the emotional support. The reason this is difficult is because, unlike cancer, where there's a clear cliff, when a patient has a cancer that's unresponsive to chemotherapy or radiation therapy, and they clearly transition from life-extending and curative chemotherapy to palliative chemotherapy. In heart failure, patients will often have a drop in their physical functioning, and then they get better over a period of time, in which we're trying to extend this period of time, and now it is extending with some of the therapies, but not so much with the heart failure preserved ejection fraction population. But then they can have acute declines, and sometimes they never get back to where they were before. And in those patients who have a precipitous decline, then you have to address end of life very aggressively. But sometimes it happens over the course of years. And this is where palliative care gets involved right around this inflection point and helps you as the patient approaches the end of life. But the palliative care team is an important component of the advanced heart failure team. Their goal is to improve the quality of life by preventing and relieving suffering, because we often will spend a lot of effort on trying to improve survival when it's not going to change outcomes. They provide support to family, and remember that palliative care is not the same as hospice or end-of-life care, and that you can still have life-extending therapies and focus on controlling the hypertension, controlling their volume while you're controlling their symptoms. It can be co-administered with disease-modifying therapies, and it addresses their psychological, spiritual, and physical needs. Once again, they can be key in the discussions about goals of care and preferences, as well as planning for the anticipated death, including coming up with legacy projects, such as allowing patients to leave recordings and videos for their loved ones for landmarks in their lives that they won't be able to share in. And then finally, to address the risks to these patients. There is a value of continued involvement of you, the cardiologist, the nurses, the specialist, as the palliative care team works together. It reduces odds of admissions when the primary care physician is still involved, and there are a lot of interventions that can be used to improve readmissions. So in conclusion, the diagnosis of heart failure with preserved ejection fraction remains quite challenging. We do need to develop better strategies for implementation into clinical practice and to prevent progression of disease. But the key is that we need increased empiric data, efficacy data, looking at outcomes in patients with preserved ejection fraction. And now with the phenotypes, with the ability to better characterize these patients and to identify the appropriate patient for clinical trials, I hope that in the next 3 to 5 years, we will start having more options for treating and preventing heart failure with preserved ejection fraction. So question 1 is a 34-year-old woman who presents with progressive dyspnea on exertion, fatigue, and peripheral edema. She has a past medical history of hypertension for 2 years and diabetes for 3 years. Her blood pressure is 124/70, heart rate is 80 beats per minute, and her examination is notable for an elevated jugular venous pressure of 9 centimeters of water with a positive hepatojugular reflux. She has a physiologically split S2, a 1 out of 6 holosystolic murmur, loudest at the apex, and her lungs are clear to auscultation. There's 1+ edema, and her legs are warm to palpation. She underwent an echocardiogram which revealed diastolic dysfunction, and there was moderate left ventricular hypertrophy with moderate mitral regurgitation, as well as moderate tricuspid regurgitation and aortic insufficiency. Her ejection fraction was calculated as 65%. In addition to diuresis, what other next steps would you consider? A, coronary angiogram. B, ambulatory blood pressure monitoring. C, cardiac PET scan or MRI. D, standard Bruce protocol stress test. I think the most appropriate next step is a cardiac PET scan or cardiac MRI. The reason is because the mean age for heart failure with preserved ejection fraction is really 74. It tends to be a disease of the elderly, with approximately 50% of them being women. Here we have a 34-year-old woman who has HFpEF, so that raises a red flag already. Whenever you see a patient who's younger, you want to consider other etiologies. You have to take a careful history to ensure that they haven't been exposed to anthracyclines or radiation, or been in an area that's endemic for tuberculosis, such that they could lead to restrictive cardiomyopathy or constrictive pericarditis. But you also want to look for infiltrative processes and radiation-induced disease. The other concern is that the wall thickness is much higher than I would have anticipated. As you know, it takes sometimes 20 to 25 years to develop significant hypertrophy in response to uncontrolled hypertension. Here, she has a diagnosis of hypertension for only 2 years, and her blood pressure is reasonably controlled. So in order to get this degree of hypertension, she will have needed to have some coarctation of the aorta, such that she was exposed to hypertension for over 20 years. You can certainly look for that, but in the absence of this, I would be concerned about other diseases such as Fabry's disease. But the other issue is that she has leakiness in her valves, involving almost all of her valves. And you see this in amyloidosis. And even though this is a young age for amyloid cardiomyopathy, this would be something to consider as well. So a cardiac PET scan or MRI can actually shed some light here. The reason I wouldn't reach for a coronary angiogram initially is because this patient is only 34 years old and has only had diabetes for 3 years. So her chance, in the absence of cocaine use or concomitant cigarettes, the chance of significant coronary disease is lower. The ambulatory blood pressure monitoring wouldn't help you as much either, because we know that her systolic blood pressure is close to the target range. And so even if she has intermittent hypertension, it wouldn't really shed light into what direction we should go in her management. And then finally, the standard Bruce protocol wouldn't be as helpful if we know that she's has a reasonable functional capacity. The only reason I would do this is if you couldn't trust her history. Question 2 is a 74-year-old woman who presents with 2 years of progressive dyspnea on exertion without a clear etiology. Echocardiogram was notable for no diastolic dysfunction or valvular disease, and the ejection fraction was 55%. What are the possible explanations for her dyspnea? A, lung congestion. B, chronotropic incompetence. C, pulmonary hypertension. D, skeletal muscle weakness. E, all of the above. The correct answer is E, all of the above. I just want to remind you that in heart failure with preserved ejection fraction, there are 5 key clinical presentation phenotypes. The first is lung congestion, where the predominant cause of their symptoms in their HFpEF is their overall volume retention, and you would want to use diuretics and aggressively treat these patients. But we also know that chronic tropic incompetence is the second phenotype. And in fact, she's 74 years of age and she could have sick sinus syndrome and thus chronotropic incompetence. This could be assessed by exercising her and measuring her heart rate or doing a formal stress test to see what the heart rate responsiveness is. And in patients who are on 2 nodal agents, once again, you can reduce one of them or reduce the dose to see if you can improve their symptoms. Undiagnosed pulmonary hypertension is a third phenotype that may be a contributing factor. And skeletal muscle weakness can also contribute to symptoms in patients with HFpEF. And I want to just remind you that one can have sarcopenia or the apoptosis or loss of muscle mass even in the presence of obesity. And so you would want to look for sarcopenia as a possible cause, as an exercise training program may dramatically improve their symptoms. And then finally, we don't want to forget about atrial fibrillation. Some people are very symptomatic from their paroxysmal or their persistent atrial fibrillation. So you want to make sure that you treat them aggressively.